Hello, I'm VictoriaKhomazjuk, Associate Professor of the Department of Propedeutics of Internal Medicine number 2 from Bogomolets National Medical University. And our today's lecture is devoted to the chief signs and syndromes of arterial hypertension. First of all, I'd like to remind you a pathogenesis of the arterial hypertension. This scheme shows you that blood pressure depends on cardiac output and peripheral resistance growth. If they are increased, we receive hypertension. And you see here a lot of factors that may contribute to the development of the hypertension. Next scheme is going to remind you about one of the main mechanisms of the regulation of the blood pressure. It is renin-angiotensin mechanism, aldosterone mechanism. It's very essential now because we have a lot of drugs which are working to stop this pathologic circle which leads to the elevation of the blood pressure. Next scheme shows you that elevation of the blood pressure leads to such not good effects as left ventricular hypertrophy. Their left ventricular hypertrophy may contribute to the development of the arrhythmias and to the development of systolic or diastolic dysfunction of the left ventricle and so the development of the heart failure. We see the contemporary classification of the blood pressure levels according to the guidelines of the European Society of Cardiology and the European Society of Hypertension. And we see that we consider hypertension if the blood pressure is higher than 140 systolic and 90 diastolic. If it is less, it is not considered hypertension in Europe, but we see that we have category of the high normal blood pressure, and in most of guidelines they advise when we treat hypertension to lower the blood pressure to the level which is considered normal, this one. So it should be less than 130 and less than 85. Well, and we see that in European classification we have 3 grades of hypertension. It may be mild, moderate, or severe. We also have the isolated systolic hypertension, which is specific mostly for adult patients, when the systolic blood pressure is elevated, but diastolic may be normal. If we compare the guidelines of the American College of Cardiologists and American Heart Association, so we see that in the United States now the high blood pressure is more than 130 and for systolic and 80 for diastolic. So they have more strict recommendation now. They introduced them in 2017, and they have only 2 stages of the hypertension. Stage number 2 is the level of pressure that is considered hypertension, considered the beginning of hypertension in Europe. Oh, wow. And also we have here the category of hypertensive crisis. They mean that it is pressure more than 180 systolic and 120 diastolic. Oh, wow. So let's speak about CVD or cardiovascular diseases risk. Yeah. In European countries, the prevalence of hypertension now is something around 30 to 45% of population. It's very high, and the relationship to the CVD or cardiac diseases. Uh, for this, blood pressure is an independent risk factor. And you see that each increment only for 20 millimeters hydrargyrum doubles the risk of the cardiovascular diseases at each level. What are the benefits of lowering blood pressure? If we lower blood pressure, so we lower the incidence of stroke, myocardial infarction, and heart failure. And this is the table from the previous years, where you should see, but it's still working, that not all patients are aware that they have high blood pressure. Look, less than half at the beginning of in the middle of the last century, and at the beginning of 20s, only 70% of patients may know that they have really high blood pressure. Only 59 of them receive treatment, and only 34 of them really control the level of the blood pressure. So we need to change this situation to prevent complications that we speak before. Oh, well. And what we need to do for diagnostic evaluation of the hypertension. At the initial examination, first of all, we need to confirm the diagnosis of hypertension. Then we assess the cardiovascular risk, the organ damage, and concomitant clinical conditions. And we should differentiate if the hypertension is essential or secondary. And this diagnostic evaluation includes medical history, including family history, physical examination, including careful blood pressure measurement, and laboratory investigation and diagnostic tests. And these two you already acknowledged how to do. And about laboratory investigations and diagnostic tests, we will also speak during our lecture. Oh, well, so first of all, about BP measurement techniques. First of all, we use, of course, in-office measurement of the blood pressure. It means when the patient comes to you, to the doctor for the visit, you measure blood pressure. It should be at least 2 readings, 5 minutes apart, when the patient is sitting in a chair. And you should measure the blood pressure on both arms. Then, if we have some doubts about diagnosis of hypertension, we can use ambulatory BP monitoring. It means monitoring of blood pressure for 24 hours or even more if it is needed. And this one is used for evaluation of so-called white coat hypertension, because your patient may react only for the meeting with someone in the white coat, and this is stressful situation, and the blood pressure in this case may be higher than usual. Well, and also we use self-measurement of blood pressure. So the patient measures blood pressure on his or her own at home, record these results, and tell about them to the doctor, to the family doctor. And such measurements is also useful. It provides information about response to the antihypertensive therapy. Well, so what about office blood pressure measurements? It should be strict rules of measurement of blood pressure to avoid mistakes. First of all, we use auscultatory method for measurement. Patient should be seated for 5 minutes in a chair, feet on the floor and arms supported at heart level. Then it should be appropriate sized cuff. Then at least 2 measurements should be made, and you should provide to patient the numbers of the blood pressure that you measured, and tell him what are the goals, so what level of the blood pressure should be achieved after treatment. Wow. And this is to remind you that, of course, we use auscultatory method for measurement blood pressure, but before auscultation, you should use palpation of the brachial or radial pulse to ensure that you inflate the cuff to right level. Because if you don't use palpation, you may stop inflating at auscultatory gap and the blood pressure may be underestimated. These are guidelines in measuring of blood pressure. Once more, for most patients we use sitting pressures during routine follow-up. So the patient should be sit with back supported for 5 minutes, arms supported at the level of the heart. Very important now to use coffee for preceding hour, not smoking for 30 minutes, and no use of some stimulants like drugs, for example, epinephrine or decongestants. Then you may take home readings under different circumstances throughout the day. Well, next, what about equipment? The cuff size should be appropriate. The bladder should encircle and cover 2/3 of the length of the arm. If not, it should be placed over the brachial artery. If it is too small, so you may receive high readings, so higher than in reality. Then you should check manometer, and as you know, the gold standard for blood pressure measurement is mercury manometer. For small children and infants, we can use Doppler ultrasound equipment, but of course in routine practice in adults it is not used. Next, about technique. On each occasion, you should take at least 2 readings, separated by 5 minutes. Then, if readings vary more than 5 millimeters, you may take additional readings until 2 are close. Then, for diagnosis, you need to obtain at least 3 sets of such readings. So it will be at least 3 visits of the patient, and if at all of these 3 visits the blood pressure is elevated, you can make the diagnosis of hypertension. And with home measurements also obtain multiple readings over for 3 to 4 weeks. Initially, you should take blood pressure on both arms. If pressure differs, you will use the arm where the pressure is higher. If arm pressure is elevated, especially in young person, you should take blood pressure on one leg to exclude the secondary cause of hypertension, such as coarctation of aorta. Oh well, so performance. You should inflate the bladder quickly to a pressure 20 millimeters above the systolic pressure that was recognized by the disappearance of the radial pulse. So when you inflate the cuff, you use pulse, radial or brachial. When the pulse disappears, you inflate 20 millimeters higher and only then begin to deflate. Then here you see the speed of deflation of bladder. Then you record Korotkov phase 5. Usually for disappearance of sounds, it will be diastolic pressure. Oh, well. About recordings. When you record the results of your measurement, it is essential to note the pressure, position of the patient, on which arm did you measure the pressure, and the cuff size. Here is the example of such recording. Oh, well, next technique that we can use for measuring of blood pressure is ambulatory BP monitoring. It is used for evaluation of the white coat hypertension in the absence of the target organ injury. Well, and the levels of such pressure will be less than the level of the pressure measured in clinic, in office. Yeah? So if your patient has hypertension, so the average BP will be higher than 135 to 85 during the day. You remember in office measurement higher than 140 to 90. Here it is, the border is lower. Then during the night, the level in hypertension will be more than 120 to 70. So in healthy person, the pressure at night should be lower than 120 to 70. And the BP should drop during the night for 10 to 20%. If there is no such, if it not happens, the risk of the cardiovascular events is high. And this is the example of the diagram of the BP ambulatory monitoring. The dots show the heart rate, and the lines show systolic and diastolic blood pressure. It was measured every 15 minutes during the day and every half an hour during the night. And you see here that the blood pressure drops during the night period. This is normal. And here we see that there are some measurements which are higher than 140, but we use the figure of the average level of the blood pressure during the day and during the night. That's why this diagram is considered normal. Wow. Self-measurement of blood pressure provides the information about response to the therapy, and also it is used for evaluating of the white coat hypertension. So the level of the home measurement more than 135 to 85 is considered to be hypertensive. And here we see the table which show us once more the norms for the blood pressure if which is measured by different technique, and in which case we may diagnose, make a diagnosis of hypertension. This one shows us how to use the results of different techniques together to make a diagnosis of the hypertension, masked hypertension, or white coat hypertension. Oh well, patient evaluation. So to evaluate or to examine the patient with high blood pressure, we use not only the measurement of blood pressure, so we have a lot of other objectives. First of all, we assess the lifestyle to find out cardiovascular risk factors or concomitant disorders because they affect prognosis. Then we try to reveal identifiable causes of the high blood pressure. So we need to differentiate essential hypertension from secondary causes of hypertension. And at last, we try to assess the present or absence of the target organ damage. So this is the list of the cardiovascular disease risk factors. There are a lot of them, and hypertension is one of them, of course, but we need to check for all of them, first of all, during history taking, but also according to the laboratory test. For example, we can find microalbuminuria or estimate glomerular filtration rate to check the function of the kidneys. What are identifiable causes of hypertension or so-called secondary hypertension? The most usual is chronic kidney disease. It is associated with the high blood pressure. Then it may be also primary aldosteronism. This is the disease of the adrenal glands. Then it may be also sleep apnea. And you see a lot of other reasons. Most of them are endocrine. Oh, well, what may be signs suggesting that our patient has secondary hypertension? Features of Cushing syndrome during general inspection. It may be changes on the skin due to pheochromocytoma. Then we can palpate enlarged kidneys in polycystic kidney disease. Then we may auscultate abdominal murmurs in case of renal vascular hypertension, or precordial and chest murmurs in case of diseases of aorta. And also we can find diminished or delayed femoral pulses and reduced femoral blood pressure in case of aortic coarctations, which mean narrowing of aorta at some level in the chest or abdomen. Oh, well, this is to remind you how looks like the patient with the Cushing syndrome, specific obesity, this purplish stria, and moon-like face. This is specific for the diseases of the adrenal glands or hyperproduction of steroid hormones. Then thyroid disease with enlargement of the thyroid gland and hyperfunction or hypofunction may also lead to the elevation of the blood pressure. Oh, wow. The third goal of examination of patient with hypertension is search for target organ damage. Here we see the most organs which suffer from high blood pressure. It is heart, brain, eyes, kidneys, and peripheral arteries. So, as for the heart, the main consequence, first of all, will be left ventricular hypertrophy. Then it may be angina or myocardial infarction, and the result, it may be heart failure. As for brain, of course, it may be stroke, it may be retinopathy. Chronic kidney disease may be not only the cause of hypertension, but also the consequence of the essential hypertension. And atherosclerotic lesions lead to the affection of the peripheral arteries. What may be the signs of organ damage? As for heart, it may be shift of apical impulse to the left due to left ventricular hypertrophy. It may be arrhythmias. It may be ventricular gallop, pulmonary rales, and edema in case of heart failure. As for brain, we can hear murmurs or broods over the neck arteries if they are narrowed by atherosclerosis. Then we can see fundoscopic abnormalities due to hypertension. And in case of affection of peripheral arteries, we can find absence, reduction, or asymmetry of pulses on hands or legs, cold extremities, and ischemic skin lesions. This is the list of routine tests, laboratory tests that should be done to each patient with high blood pressure. This is the picture which shows us left ventricular hypertrophy. It means thickening of the wall of the left ventricle. There is cross section of the heart. Here is left ventricle, this very thick wall, and here is the right ventricle. Its wall is much thinner. How can we assess left ventricular hypertrophy? First of all, on the ECG, you see high amplitude of the R waves in the left leads, which are 1, AVL, V5, and V6. And we see deep S waves in the third lead and in lead V1. We also see negative T waves and depression of ST due to overloads over the left ventricle. One more picture of the left ventricular hypertrophy with high R in the first, V5, V6, with depression of ST and negative T. Well, but for the diagnosis of left ventricular hypertrophy, more accurate will be the result of echocardiographic examination. We can calculate the left ventricular mass, and left ventricular mass index is considered specific for hypertrophy if it is more than 95 grams per meter squared in women and more than 115 in men. And these figures are used for estimation of the LVH. And this is the picture of the long axis view of the left ventricle on the echocardiogram. Here is the cavity of the left ventricle, that is its posterior wall, and its thickness is measured. Here is interventricular septum. We also measure the thickness, and we measure the diameter of the ventricle, and all these measurements are used to calculate left ventricular mass. And depending on the results of these measurements, we can make a diagnosis of concentric left ventricular hypertrophy in case if only the walls are thick but the cavity is normal, or we can make a diagnosis of eccentric LVH. In this case, the walls are not thick, they are normal, but the cavity of the left ventricle is enlarged. It is distended, and this type of hypertrophy is called eccentric. Oh wow. If, according to the routine tests and examination, we find some more changes, so we proceed with more profound examination. And here we see the list of the tests which may be used for, or the additional test to make diagnosis of hypertension more accurate. Then the extended evaluation, which is domain of the specialist, it means cardiologist. In this case, you may use the more complex techniques. For example, in case of complicated hypertension, you will search for further cerebral, cardiac, renal, or vascular damage. And you may search for secondary hypertension. In this case, you will measure the levels of hormones of renin, aldosterone, corticosteroids, catecholamines. You may produce arteriography to see the stenosis of the vessels. And you may use ultrasound, renal and adrenal, or CT to see the tumors of the adrenal glands, or some polycystic disease of the kidneys, for example. And brain magnetic resonance imaging to see the signs of brain ischemia. Well, this is the example of the angiography of the patient with renal artery stenosis, and you can see here that contrast was introduced into the aorta, and we see that this kidney is normal and renal artery is good enough, but on the right side we see that renal artery is thin, it is stenosed, that's why the kidney is diminished. So this is the example of renal vascular secondary hypertension. Well, and also as the result of your examination of the patient with hypertension, you need to assess cardiovascular risk for your patient, that the risk of complication, the prognosis for the longeviness of the life, and the changes in the life. Well, what will you use to assess the risk? You will use blood pressure category. It means what grade of hypertension. You will use the presence of the risk factors and the presence of the organ damage, presence of diabetes mellitus and chronic kidney disease. And look, this here, the list of risk factors, especially for hypertension, yeah. And we see here that there are not only a list of factors, but also you can see figures and values, which level of changes is real risk. Then you can see the special table how to assess cardiovascular risk. For example, if the patient have no risk factors and his blood pressure is normal, it will be no risk at all. But even if your blood pressure is normal, but you have risk factors, your risk is growing and maybe even very high in case of symptomatic cardiovascular disease, for example, ischemic heart disease, or diseases of the kidneys, or diabetes. Oh, well, here we have also the list of causes of the resistant hypertension. What does it mean, resistant hypertension? It means that when you treat and give your patients more than 3 drugs to lower blood pressure, and there is no result for at least after 3 or 4 weeks, such hypertension will be considered resistant, and we see that there are a lot of causes for this, but on the first place it is improper blood pressure measurement. So we need to study how to measure blood pressure carefully. Oh, well, and also you may see which medication can affect the levels of blood pressure and treatment, antihypertensive treatment. And we also need to say a few words about postural hypotension. It means that when the patient lies down and then quickly stand up, the blood pressure systolic may decrease rapidly. And if this decrease is more than 10 millimeters, so it may be associated with dizziness or even fainting. And such reaction is more frequent in older patient with systolic high blood pressure, especially patients with diabetes or those who are taking diuretics. So in such individuals, BP should be monitored in the upright position. Wow. This is all that I want to tell you today about hypertension. I hope that this lecture will be useful for you, and we will finish our lecture today. Thank you. Goodbye.